So this was one of the animations that we saw earlier, where when there is water loss, there is a dehydrated cell, but you can't have a whole tissue shrinking. So what does the cell do? It does what it calls regulatory volume increase. And it does that by imbibing certain salts, so the cell volume gets restored. But what also happens is that it brings in too much of sodium, potassium, magnesium, and all these electrolytes, and this causes a decrease in cell function because there's now hypernatremia and hyperkalemia within the cell, and that produces cell damage and apoptosis. So this is the vicious cycle that is there now, and I've just taken the major parts of this, wherein tear hyperosmolarity here is what adds to this whole process, leading to apoptosis of the ocular surface. The ocular surface damage starts fairly soon, and within a day and a half, there is activation of the stress kinases, and from acute epithelial disease, it becomes chronic surface damage with the involvement of the T cells, and that happens usually within a week of the onset of the hyperosmolar stress. So what happens, and how can the cell help itself by not going through this process? Now, we knew that there was a regulatory volume intake and there was cell death because of apoptosis, but there is another column or another mechanism that the cell has, which is that it can bring in a regulatory volume intake, which is by what we call compatible solutes. And compatible solutes are essentially molecules which will bring in osmolar power without interfering with cell function. So they are essentially substances which do not involve themselves in the cell metabolism, and these are called osmoprotectants. And these are found in many, many tissues inside the body, especially the heart and the kidneys, where there's a lot of hyperosmolar stress. But unfortunately, the ocular surface does not have the capacity to synthesize compatible solutes, and so these compatible solutes have to be provided externally. So these are some of those that are available in various species in nature. They are the methylamines, they are polyols, they are amino acids and small carbohydrates, and some of these are now being introduced into these ocular fluids that we have, that we can use as eye drops for supplements. So the goal of treatment in DED is to improve the patient's quality of life and symptoms, and to prevent the patient from entering the vicious circle, or to promote the exit from there, and to prevent anything entering into the circle which is a causative factor such as environment and other systemic disease, and promoting the exit from the vicious circle, which involves addressing the central mechanisms such as tear film instability, inflammation, and tear hyperosmolarity. And there's an expanding pool of clinical data that suggests that osmoprotectants are fairly effective. Glycerol and erythritol, for example, are small polyols. They work very quickly through the water channels, but they also leave very quickly. In contrast, the amino acids like carnitine, which are taken up via amino acid transporters and are retained for longer periods. And it are these kinetic properties, when they are properly balanced, that makes a product or a tear film substitute ideal. So you have very rapidly moving items, medium speed of moving items, and those which have to be actively transported across the cell membrane. And it is the proper combination of these which works to make an overall protection better. The lab studies have shown that these osmoprotectants are very effective. Here there's a study which showed that the activation of these enzymes was reduced in the presence of osmoprotectants like L-carnitine and erythritol. There are more that have shown that there are a reduction in the expression of the enzyme stress at various osmolarity levels when these human epithelial cells are cultured in the presence of these osmoprotectants. And there is clinical evidence as well, and there are various studies which are showing the comparison between drugs which contain osmoprotectants versus those that are not, and they're showing that the comfort as well as the OSDI scores are better. There's a switchover trial with more than 5,000 dry eye patients which revealed that there was a better ocular comfort, improvement in clinical signs and symptoms after a few weeks, and an improvement in the T-butt or the tear film breakup time. So the ordinary artificial tears that we have are only surface active, but those that contain osmoprotectants are actually adding to the value intracellularly as well. Evidence is getting more stronger and more compelling, and the role of L-carnitine in protecting the ocular surface is there. And we know that the L-carnitine levels are much lower in patients with dry eye, and thereby I think the possibility of supplementation even orally can then be considered. To summarize, dry eye is produces significant ocular surface damage which is mediated by hyperosmolarity, and which is one of the key mechanisms in the evolution of the dry eye. And cells ordinarily use short-term inorganic solutes and long-term compatible solute regulatory environments. Hypotonic solutions provide only very transient relief. Compatible solutes help regulate the osmolar balance and provide osmoprotection, and there is mounting clinical evidence of the beneficial effect of all of these. And incorporating compatible solutes with different kinetic properties may be more effective in protecting patients from dry eye. Thanks very much. I'm going to now request Professor Rajesh Sinha, and he's going to be giving us his talk on Meibomian gland dysfunction, and we'll also be discussing certain newer paradigms, as well as we'll move into the realm of molecules, and he'll be talking about chloroquine.
Thanks, Dr. Rishi, for including me in this course. I'll first be talking about Meibomian gland dysfunction. Well, this is a very common disorder, a very common problem that occurs in, that we face in our day-to-day. The slide is not changing. Yeah. In our day-to-day practice. And in a routine Meibomian gland dysfunction, we can still manage with lubricants, a little bit of warm lid compresses, but there are many scenarios when we get to see these refractory MGDs which don't respond. You have cysts in the lid margin, and all these are a major problem. It can be associated with, altered secretions, heaping up at the edge of the Meibomian ducts. And then when you examine the glands by mammography, you see that the glands drop out, and the patient has increasing symptoms. And all these things are more often seen when you see that an old individual coming to your OPD, and when you see invariably many of these individuals, they have this MGD. So increasing age is a factor. Of course, contact lens wear, hormonal imbalance, particularly in females. Poor hygiene is very important. And of course, environmental factor is really coming up very fast these days, and people are knowing about it, that these are causing problems. And of course, individual susceptibility is an issue. Acne rosacea is another important cause of severe MGD. So if you have an MGD which is not responding to your routine treatment, that you can consider it as a refractory MGD. Now, what is the routine treatment of MGD? Well, any patient, if you examine the lid margin, see heaped up secretions, obviously you initially start with warm lid compresses, and then a little bit of lid massage that can be done by various methods, and you give some anti-inflammatory agents to take care of it. So if all these routine measures, they don't work, then you go further. And what is that further? You start oral doxycycline. Now, there are a couple of studies which have compared the various dosage of oral doxycycline. Now, this is the earlier established the dosage was 100 milligram twice a day for a week, followed by 100 milligram once a day for 6 weeks. Now, there was a study which, a major study which compared this dosage with 100 milligram once a day from the very beginning, and they found out that the result was similar, comparable. So these days, people are preferring 100 milligram once a day oral doxycycline for 6 weeks. And of course, there are certain topical immunomodulators which are very useful, like topical steroids and topical cyclosporins, which again they help a lot in managing these cases. Now, if there is acne rosacea, ocular rosacea, then of course doxycycline is very useful. You should also take some preventive measures, like you should avoid products that contain alcohol, menthol, exfoliating agents. You should avoid cosmetics, too much of cosmetics, and you should use protective goggles, etc. And as I said, oral doxycycline is very useful in MGD. Oral omega-3 fatty acids is also showing very good results these days. And some people have used, some studies have shown good results of topical metronidazole gel as well for these. But what is most important is that you have to do an active expression of the secretions, because these are clogging the ducts of Meibomian gland. And for that, you do warm lid compresses, you do a little bit of massage. If that doesn't work, then with the help of a swab stick, you can press, you can do probing, and you can get out the secretions. You can even use a simple spatula, and that helps to, you know, keep the lid surface on it, and then you can do a massage. You can oppose the two lids as well and then do a massage. So there are various ways. The basic idea of all these methods, all these expressors, is to express the secretions that have clogged up in the ducts of Meibomian gland. And this is an upcoming method which is becoming quite popular, although a little costlier. But this LipiFlow method is, you provide heat simultaneously and you do a thermal pulsation. You have a thermal pulsation system. So as you can see here, you provide heat from inside the plate. Do you have a pointer? You provide the heat from inside and you have a thermal pulsator from outside the lid. So in that case, you have a simultaneous heat and pressure, and that really helps in expressing out the Meibomian secretions. And there are certain lid scrubs as well, because many times you get these secretions to form crusting over here, and even if you express it, even if you press it, it's not going to get expressed out. So you have to, you know, use the scrub to remove these crusts from the lid margin. That is very, very important. And it's a sort of a disease which is treated by lifestyle modification. We require some change in diet. We can use fatty fish, we can use humidifiers. If all these things are not you know, very much working, you can take omega-3 supplements as well, as I said, because these are really useful. Of course, along with that, we can have other problems of lid related to Meibomian gland dysfunction, and that has to be handled, handling chalazion or trichytic eyelash, entropion or ectropion. That can happen in Meibomian gland dysfunction as well. So what is most important in Meibomian gland dysfunction is explaining the patient to adhere to whatever you are guiding, because it is very easy to put the drops, it is very easy to take the tablets, but to maintain the lid hygiene, which is the most important thing, you know, expressing the secretions from the ducts of the Meibomian gland, which is most important thing. These things one should adhere to, and of course, if there are crusts at the orifices, that needs to be removed by these scrubs. And a combination of all these factors, like you know, interventions, environmental factors, dietary factors, and the eye drops, as well as sometimes you have to do some probing, etc. All these factors, depending upon the severity of Meibomian gland dysfunction, is essential in order to have a symptom-free patient and resolution of symptoms. Thank you very much. Can I have the next one, please? Can I have the next one? Next presentation. Yeah. Go here. So, are you doing or shall I do? So, I'll be talking about post-surgical ocular homeostasis. Now, we are all surgeons. We all, some of us are refractive surgeons, some of us are cataract surgeons, some of us are corneal surgeons, some of us are retinal surgeons. I mean, we have a combination, the whole gamut is here in this meeting. So we all are very keen and very, fond of doing surgeries. And what are the issues that we have after a successful surgery? What we want? As an ophthalmologist, I would like to have a good visual outcome, and all of us want that. If we have done a cataract surgery, we want the IOL to be absolutely well centered. If we have done a retinal surgery, then we want the retina to be settled. Glaucoma surgery, we want a nice bleb and a normal IOP. And if we have done a refractive surgery, we want a good visual outcome and the flap to be absolutely normal without any stria or dislocation, etc. And once we get all these things, we are very happy. But what happens is that some of the patients are not very happy. We may say that the results are very good, but the patients are uncomfortable. Why? Because they have the symptoms of irritation, redness, foreign body sensation, and these things are becoming very common these days. And earlier, the issue of getting 6x6 vision was the major criteria of having a successful surgery. But now we want the patient to be happy, we want the patient to be comfortable, because the 6/6 issue is no more there. So what is the major factor that causes these symptoms? The major factor is that all these symptoms are ocular surface related. So there is something wrong in the ocular surface homeostasis. And what we found out, people have found out that this disturbed ocular homeostasis is basically because of inadequate ocular surface hydration. Now, why we do have inadequate ocular surface hydration? Suppose we have done a LASIK surgery. What we do, we create a flap, we cut the nerves, we put the drops. This is the normal neuronal flow, loop which requires for a normal tear secretion. But if we cut the nerves, it cuts somewhere, and that creates reduction in tear film. And this is one survey which was done on the patients who were dissatisfied with LASIK. And 1 out of 5 individuals were dissatisfied because of ocular surface disorder. So that comprises of a very huge proportion. Then after cataract surgery also, people have found out that patients are symptomatic. And why? Because of disturbed ocular surface. Then people thought that, and it affects, because these days we are implanting premium IOLs, and the results of premium IOLs, they get affected if the ocular surface is not good. Why they have it? Because most of these patients are old, and they are already, they are predisposed to Meibomian Gland Dysfunction and disturbed ocular surface. Some of these are perimenopausal females because of hormonal imbalance. Some of these are having Meibomian Gland Dysfunction, as I was discussing. Some of these patients have coexisting glaucoma, and they are taking anti-glaucoma medications, which are very, which play a major factor, a major role in causing ocular surface disorder. And of course, when we do a surgery, we alter the corneal curvature, so the breakup time becomes fast. There can be inflammation. You cut the nerves as well. You do additional procedures, like we want a 6/6 vision unaided, so we want to correct the astigmatism. So we do